we have our Dr. Thomas to talk to us on can opener ILM peel. I don't know why they also wanted to do the can opener. Over to you. Thank you.
I'll explain. Thank you, Dr. Satyan. In fact, this was the technique which I had to develop out of frustration. I usually keep my macula holes towards the noon time. I start off with my regardis, then diabetics, then I go for my macula holes. That's my practice, that's all. One day I finished all my morning cases, the regardis went off fine, the diabetic was okay. And when I was trying to catch the ILM in my macula hole, I was not able to do it. I had a fine tremor. So I tried for some time, then I closed. Frustrated, I went. But then 1 or 2 weeks, nothing happened. Then again, the same thing recurred. And I was trying to figure out why this happened. And then I got the reason. I had taken a bronchodilator on the previous evening. And I was developing fine tremors. So I was not able to catch the ILM. Then I thought, I've been after these ILMs for quite a long time and should not let this ILM rule me. So I devised this, I tried this, I didn't devise it. Of course, I tried this technique. Yeah, that's how you induce a posterior vitreous detachment with the help of triamcinolone. All that has come off. And then you inject your brilliant blue green, stain it, and then I put multiple nicks in that stained area around. Multiple nicks, just like how you do it on the anterior capsule for a can opener capsulotomy. So multiple nicks, and then I joined a couple of those nicks. So at multiple points to pick up, not just one point after you put your first nick, or if you pinch and peel, you don't have even that one single point. Here I had multiple points to pick up. Here also you see I am having a fine tremor there, but I could overcome that tremor and pick up the ILM. Yeah, after that you do your fluid air exchange and air gas exchange as usual and close, and you have your macula hole closed. So that's why I said this was a technique which was devised out of compulsion and not for anything else. Thank you.
Thank you so much, Dr. Thomas. Wonderful, actually. Problem is always should be there for us to innovate something new. So I think it is so nice. Probably for your tremors, you should have taken a propranolol. That could have been easier. And definitely this looks very nice. The can opener with the continuous curvilinear also is there, actually. Both you have combined together. Thank you so much.
And
it looks
later
so nice.
on, I revised it because the first few cases I did that can opener all round. But then I thought it's not good to do that can opener over the papillomacular bundle. So I started doing a semi can opener. That's almost a 270 degree. And then you come back over the papillomacular bundle, you just peel once.
Yeah. Something similar to a double Rex is kind of.
Yeah. So
that
was a modification which I adopted later on.
Yeah. It looks nice, actually. Thank you. Because I have no idea about this stuff. So I think somebody who has better knowledge than me can ask some interesting questions on this. Madam, you have anything? Anybody in the participants or in the audience can ask some interesting questions if you have. Because I thought this is a very important and interesting session actually, because it's all very practical and where you can go back and practice these things. Very simple, small tips as a take home is very. I thought it is one of the most important sessions. I thought. Thank you, and really thanks for calling me for this particular session actually.
Thank you, and I thank all the speakers for giving up their innovative surgical techniques, showing their innovative surgical techniques here. And thank all the audience for being here today. Thank you. Since we are one speaker less, we are winding ahead of time.